Hello everybody, welcome to today's webinar and welcome to National Science Week. I wonder whether you've been catching up on all the different types of events that have been going on around the nation this week. If you're unsure what's going on, just check out National Science Week website and see what's going on in your area, or of course online, that you might be interested in. So to mark National Science Week, IHMRI has been or will be offering a webinar every day, covering a variety of different topics, just demonstrating the type of research that is happening right here on your doorstep, and how that research is positively impacting all of us. My name's Kate, I'm the Community Engagement and Events Coordinator at IHMRI. And to start off, I'd just like to acknowledge the Dharawal people, the traditional custodians of the land on which IHMRI sits. I would also like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal people present on the webinar today. Today's webinar, as you know, is all about pain management and care. What is pain? What are the different types of pain? And the challenges that all health professionals face when treating pain, and the challenges, of course, that patients experience when they're living with chronic pain. So our panelists will be taking questions from you, so please feel free to use the Q&A function in the webinar, and you should see that just at the bottom of your screen, the Q&A function. And there's also a chat function, and I encourage anyone to share any experiences that they might like to in the chat function. So today we have with us Janelle White. Janelle is the Acting Director of the Electronic Persistent Pain Outcomes Collaboration, known as ePPOC. She's a clinical nurse consultant in pain and a paramedic specialist with extensive experience in clinical healthcare research and the development in primary care, particularly in chronic and complex disease, integrated care and pain management. As the Acting Director of ePPOC, she's able to contribute to the improvement of treatment and outcomes for people living with persistent chronic pain through quality initiatives and research. Welcome, Janelle. Also with us, we have distinguished Professor David Adams. David is the CEO and Director of IHMRI. His research focuses on investigating peptides derived from the venom of marine cone snails. I think he has some exciting things to show us during the webinar, as a novel candidate for treating chronic visceral pain. He is internationally recognised for his contributions to membrane physiology, in particular that of ion channel function and modulation using electrophysiological recording techniques. As I mentioned ago, our panel are here to answer your questions. We want this webinar to be as interactive as possible, so please let us know if you have any questions that you want to ask our panelists using the Q&A function. And a recording of today's webinar will be available for all of you. I will send that through to everyone who has registered towards the end of the week, so you can watch it again or share it with someone who wasn't able to join us today. And just for those of you who don't know, the Illawarra Health and Medical Research Institute, which is better known as IHMRI, IHMRI, is a not-for-profit charity that supports health and medical researchers in the Illawarra Shoalhaven region. We bring scientists, doctors and health professionals together to help solve our greatest challenges through research. And our scientists are working really hard to find better ways to prevent and treat illnesses and diseases such as cancer, diabetes, mental health and dementia, to name just a few. If you'd like to have a look at the other diseases that we look into and research, check out our website. It's ihmri.org.au. But I think for now we will get started on the webinar. So pain management and care. Janelle, can you just talk us through what pain is and why do we experience pain and what the different causes could be?
Sure. Thanks so much for having me. I feel very lucky to be a part of this panel, and thanks. I really appreciate you having me along. So what is pain? Well, I know it's National Science Week, but you don't have to be a scientist to understand what pain is. We've all experienced it or felt it to a certain or varying degree. Unless, of course, you are in the very small percentage of people who have a rare congenital condition called congenital insensitivity to pain. Now, before you start, these people actually don't feel pain. Now, before you start thinking, wow, how great would that be? Just stop for a minute and think, First of all, they don't live to a very old age. And secondly, imagine if you had appendicitis or you were having a heart attack, for example, you wouldn't even be aware of it until it was way too late. So actually, pain is useful and it's important. And it's useful most of the time, but we'll get to that later. So pain is our body's, if you like, inbuilt alarm system. It's our nervous system, which is a complex system, acting to detect dangerous stimuli, if you like, and sending those messages to the brain. And it then causes a reaction for us to protect the painful part that we're experiencing. So for example, if I told you to hold your hand over a flame right now, it would be a second before you'd be pulling it away because you would have felt pain. And so that's how fast that message goes to your brain and sends it back to your hand to say, move. So behind the scenes, there's a lot going on in that one split second. So put simply, there are a series of signals, if you like, from the nerves that would start in your hand over the flame. I call them the back roads. They lead to the nerves in your arm, which I like the main street of your town, and then head to the spinal cord, which is like the superhighway. And then eventually they end up at the brain. And I see the brain as like a massive interchange where a lot goes on and also signals leave the brain. And that's what eventually tells you to move your hand away quickly to stop more damage occurring. But the brain doesn't stop there. The brain also is really important as it gives meaning to the pain that you're experiencing. That's why we should never really say to someone else, oh, I know exactly how you feel when you have an injury or an illness, because actually you don't, and you never can, because pain is very individual. It's experienced by each individual person differently. That's why you can also never say, look at someone and say, well, they don't look like they're in pain, because there may not be outward signs, and pain is experienced individually by each of us. So we need to always remember that because our own brain is interpreting the pain and giving meaning to the pain, our experiences will be different because of our own different biology and psychological factors and social factors that we are involved in. And in fact, the international body responsible for researching and studying pain, the IASP, have made a formal definition to recognize this. So the formal definition for what is pain is an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. So I'm just going to quickly cover 3 types of broad pain in this short introduction. As you can imagine, there are many, many, many types of pain, but 3 broad categories are acute pain. Now, this is the pain a lot of you'll be have the most experience with, and that's anything from a bee sting to a burn to stubbing your toe to post-surgical pain. It triggers a fast reaction to protect the area or a fast healing reaction, and it arises from actual or threatened tissue damage in the body. And it responds generally well to healing or treatment, or stopping the stimulus, if you like, if you go back to the candle example before. The acute pain, though, if it's not well managed in those early stages, can develop into chronic pain, but more on that later. The second pain I'd like to mention is a broad category of nerve pain, or what doctors might call neuropathic pain. That's just pain that comes from nerves. And it can be acute. If any of you have ever hit your funny bone, you will know what nerve pain is. And also, if you've been to a dentist and had them drill and accidentally bump a nerve, you will know acute nerve pain. But chronic nerve pain is much more complex, and this is something that is caused by a lesion or disease or damage to what's called the somatosensory nervous system. Now, that's a big word. It's a fancy word, and all it means is that's the part of the nervous system that detects pressure or painful stimuli or temperature changes. So it's damage to that part of the system. And people who may experience chronic nerve pain are people with diabetes, people who've had perhaps chemotherapy medications, or post shingles. If anyone's ever had a decent bout of shingles, you'll experience neuropathic or nerve pain. But before I do the chronic pain definition, Kate, you might put up, I've got a bit of a poll question to ask people. what they think the definition of chronic pain is. So the question says chronic pain is pain that lasts only 3 to 6 months, or B, has lasted more than 3 to 6 months, C, only occurs in your back, or D, occurs at the original injury site.
So when you're ready, if you just tick the answer that you think is correct, I'll just give people a few more seconds to answer that poll, and then we'll share the results and Janelle will talk us through the results. All right, ending that poll now. And here's the results. Are they right?
Oh, go to the top of the class, everyone. You're exactly right. So chronic or persistent pain. So you may hear me say the word persistent or chronic. They both mean the same thing. So chronic pain, there are, again, many types of chronic pain as well, but it is generally considered to be pain that persists beyond the normal time after injury or illness, or indeed, it's actually any pain that's lasted longer than 3 to 6 months. Chronic pain affects 1 in 5 Australians. That's 20% of us. And the average cost every year is over $130 billion in lost productivity and losses in quality of life for the people who live with chronic pain. Scientists refer to chronic pain with another fancy word called nociplastic pain. Now, the first part of that word noci just means painful stimulus, and the plastic part refers to a term called neuroplasticity, or in other words, the ability for the brain to change its activity based on certain internal or external stimuli. So they see the brain as being moldable and changeable. So chronic pain actually does change the way your brain works. And this is especially in relation to pain. So these changes can include, for example, the brain perceiving that it has pain without a stimulus, or pain that started off in a small area becoming more widespread throughout the body. Other changes that can occur as a result of changes in the brain with chronic pain are changes to sleep. It affects your sleep. It can affect your memory and your thinking skills. And it also absolutely affects mood, and especially in regard to depression and anxiety. So chronic pain sounds complicated. You're absolutely right, it is. But the good news about neuroplasticity and the brain being able to change itself for the negative, that also means that with chronic pain management, we can make those same changes back to the positive. So there is a way forward for treatment with chronic pain. But because chronic pain is complex, the management is also complex. And we'll talk a lot more about chronic pain management later. But I'll hand over to David now, who's going to take you through a little bit more about the physiology of pain.
Thank you, Janelle. It's you've covered a large part of what pain, why it's useful in terms of it's a normal alarm system, a response to damage. But you go from acute pain, which can be treated with non-steroidal anti-inflammatory agents, aspirin, Nurofen, things like that, which most people would be familiar with. The next line of treatment are what they call antidepressant medications, gabapentin, pregabalin. They're considered first-line treatments. And then for the more serious type of chronic pain, the use of opioids, and we'll certainly come back to opioids a little later. So for the past 15 years, I've had a long-standing interest in the development of new analgesics for the treatment of chronic pain. Chronic pain has two components, both in the peripheral and the central nervous system. And from my point of view, I'm interested in targeting where the pain arises, not in the brain or spinal cord, because that becomes a lot more complex and there's a lot of off-target effects. In other words, side effects of drugs. And that's really the major problem with things like opioids. So our challenge has been trying to develop new drugs that can target where the pain arises in the periphery, at what we call the nerve ending or nociceptive nerve ending. And that information is transmitted by sensory neurons that arise from dorsal root ganglia, which sit parallel to your spine. And the dorsal root ganglia innervate every tissue and organ in your body. And that detects whether it's pain in the abdomen and the colon, whether it's from your skin, whether it's from your foot. So it's the way in which information is sent to the spinal cord and then projected to the central nervous system, to your brain, to be interpreted. So perhaps, Janelle, you can take on what are some of the problems with some of the medications.
So, yeah, thanks, David. The medications are certainly a part of treatment for chronic pain for some people, but it's not the main focus of treatment for chronic pain. And indeed, with opioids, I know there's a lot of controversy about opioids in the news, and patients often feel left without any help or support when they have them removed. But there is really strong evidence that in the research that opioids actually are harmful in the long term for many reasons for people experiencing chronic pain. So not only the facts, for example, 1 in 10 Australians become addicted to opioids. In 2019, the latest data shows that there were just over 1,000 people died from opioid overdoses, and indeed just over 50% of those were unintentional overdoses from legally prescribed opioids. And currently we have about 12 Australians die each week from legally prescribed opioids. And just to give you a bit of perspective as well, with the problem, drug-related deaths are increasing by 3% every year. But compare this to the road toll related deaths, which are decreasing by 2% every year. So whilst our problem is not as bad as in the USA, it is a problem. But there are other long-term effects of opioids on the body, such as hormonal imbalances, gastrointestinal issues like constipation, dental caries, loss of libido and sexual dysfunction. It's also linked, those hormones, things can be linked to infertility. And one of the recent research findings we found with opioids is actually they can lead to worsening pain for people who are taking opioids for chronic non-cancer pain. So it can actually make the pain a little bit worse. And we just
know how would taking opioids make pain worse?
It's a very
complex.
Yeah, it's very complex, and it's not well understood, but there are a small percentage of people who take opioids with chronic non-cancer pain, and it actually causes something called hyperalgesia, meaning hyper pain, if you like. And they've seen it in a few people now. And so what is all this saying? We're not going to leave people with chronic pain. You know, what will I do without my medication? That's what part of the management of chronic pain deals with, is looking at ways to cope with your pain and facilitating and strengthening people to manage their pain without medications such as the harmful ones like opioids.
So I understand there's, this is, as you said, a hugely complex issue that is only getting worse, so something needs to change. But I understand, David, that there's lots of research being conducted into increasing options for pain medication or managing pain. Can you talk us a little bit through what's going on in that space?
Sure. So the research I've been involved in with colleagues at the University of Queensland over the past 15 years is really in the development of use of peptides for treatment of chronic pain. So peptides, what are they? Peptides are small proteins or made up of amino acids. I think a good example of one of the peptides that's been used now for 100 years is insulin for treatment of diabetes. Cyclosporin is another one that's used. So over the past 50 years, there's been increasing development of discovery of peptides that can be used for treatment of illnesses. These peptides, the ones we're interested in, have come from the venom of marine cone snails. And an example of a marine cone snail is shown here. I don't know if you can see it. So they have these beautiful patterns, and they're a collector's item. But we knew 20 years ago, or more than 20 years ago, that these are also fairly deadly. They inject the venom into their prey to immobilize and kill their prey. So they hunt fish, polychaete worms, other mollusks. Over the past 40 years, people have started looking at what's in the venom. It's made up of peptides. So there are about 800 species of cone snail. The majority are actually found on the Great Barrier Reef. And that's where we collect them from. So each cone snail would have approximately 200 or more unique peptides. And I think what's really interesting about this is that many of these peptides have been shown to be potent analgesics. So when I came into this field, we didn't know how some of these peptides work. There is one example of a peptide that came from the cone snail that was approved by the FDA in America in 2005 for treatment of chronic pain or intractable pain. It's a peptide that targets ion channels, but it has to be given intrathecally. In other words, people have to have an implantable pump to deliver it, because if it's delivered peripherally outside of the nervous system, it has an effect on the heart. So it can only be delivered directly into the spinal cord. Now, it's very effective for people who cannot tolerate opioids, and it is in use today, but it has limitations in its use. And that's why, as I've said, I've been interested in developing a peptide that will target where pain arises in the peripheral nervous system. We have identified at least half a dozen unique peptides that have come from the venom of the cone snail that do target membrane receptors and ion channels in those sensory nerves, in the nociceptive nerve endings. And by targeting those, they stop the information being transmitted to the spinal cord and to the brain. So normally pain is encoded in terms of impulse, nerve impulse firing frequency. So it sends these electrical signals at very high rates. The intensity of the pain is reflected in the frequency of action potential firing. What you want to do is try to reduce that. And that's what these peptides do. They reduce the firing frequency. And in other words, they work effectively as an analgesic. So we're at the point where we've shown in various animal pain models that they're very effective in treatment of neuropathic pain, but also in chronic visceral pain. And chronic visceral pain is most people suffer more from that than perhaps any other type of pain. This is pain such as irritable bowel syndrome. So people who suffer from irritable bowel syndrome cannot take opioids because opioids cause constipation. So there's very little else that they can use. So these peptides we've shown to be very effective in treatment of chronic visceral pain, and that would be, to me, most probably the market to target. So we've come a long way over the past 15 years. I think peptide chemistry over the past 20 years has progressed dramatically in terms of being able to synthesize these peptides, which was always the bottleneck. So the field has been dominated by small molecules for the past 50 years. It's only really in the past 30 years that peptides have come into being, particularly with techniques to synthesize these peptides and make appreciable amounts of them and make them stable. The big problem with peptides is susceptible to breakdown, proteolysis, in other words, being broken down by enzymes in the body. So, but chemists have come up with ways to stabilize these peptides and make them useful.
I think it's fascinating, David, that something that could, if you picked it up at the beach and it injected you with its barb and its venom, could potentially kill you, and now isn't it amazing that you can start to use something to deal with the really big problem of visceral pain? That's incredible research that you're doing.
Yes, look, it's as I said, people have been working on these peptides now. We've been working on them for at least 15 years. The use of cone-style peptides really started in the late 80s and has progressed rapidly. And I think we're close to getting this into clinical trials.
Fantastic. I mean, it's crucial to have an alternative to, and whilst it sounds like we're just bagging out opioids, opioids are useful for acute pain. Absolutely. In fact, as a paramedic, I wouldn't go to a job with someone with a bone sticking out of their leg and say, perhaps you should try some cognitive behavioral therapy, because they would not be very impressed. So opioids are very useful in that regard. And indeed, for some people with chronic and persistent pain, they do require some opioids, but it's when the opioids start to affect their quality of life, when the benefits of them are not outweighing the side effects, they're no longer useful or practical for them. So that's the conversation around opioids that the message I want to leave. And I see in the chat a little bit about
couple of questions there. One was, can I clarify, these peptides be given intravenously or only intrathecally? Generally, in the animal pain model studies we've done, they've been given intramuscularly, so they're injected into the animal. Having said that, we have come up, my colleagues have come up with ways to stabilize these peptides, to even make them orally active, to put the peptide in the drinking water. So that's the real game changer, I think, is to be able to make these peptides orally active, so that you don't have to inject them. The other question here is coming from with regard to the Great Barrier Reef. In the initial stages, we usually only need to collect about half a dozen of each species to get enough material to work with. Once we know the sequence, we can synthesize. So we're not harvesting a lot of cone shells from the Great Barrier Reef. There are plenty there. They're very strict in terms of license to be able to collect these. But we collect no more than half a dozen of a species. That gives us enough material to be able to determine the sequence of the peptide and to be able to synthesize it.
I also see some other questions there, Kate, if I can chat to them.
Yeah.
Yeah, about chronic pain and persistent pain. And as I said at the start, there are so many different types. In fact, migraine is a type of chronic pain, but you don't have a permanent migraine. So it's sort of a intermittent chronic type of pain. So it was actually the consumers and the community who did not like the term chronic, because they thought it sounded negative. When we mentioned chronic pain, it sounds like, oh, I'm stuck with this forever. So people and the consumers actually preferred the term persistent pain. And that was around about the time that ePPOC, with the persistent pain outcomes collaboration, was being launched. And that was through consumer knowledge and seeking their guidance about what we should be called, and that they preferred the word persistent over chronic. And so, yes, there are many different types of chronic pain, which can involve pain that comes and goes, but it's pain that people experience on an ongoing basis. I hope that.
Yeah, thanks for clearing that up for us, Janelle.
There's another question there, which is keeping it out of the circulatory system. So when you inject the peptide, it obviously gets into the circulation. The beauty of the peptides that we've been studying is that they have no effect on the heart. In other words, they don't affect the heart rate, they don't affect blood pressure. So they don't attach themselves to those receptors or channels involved in the circulatory system. And the other thing about these peptides is that they don't get across the blood-brain barrier. So if we can get a peptide that targets where the pain arises, it minimizes the side effects, which occurs when peptides are taken up into the central nervous system.
So they work completely differently then to opioids, in that they
Yes.
don't signal to the brain, they signal right to the area where the pain is, where the cause of the pain is.
Correct.
Wow.
So opioids generally get across the blood-brain barrier, and what they do is block neurotransmission through the spinal cord up to the brain. So they block that signaling at that point. Our challenge is targeting where the pain actually arises. and not to develop a peptide or drug that gets across the blood-brain barrier, but actually is restricted to the peripheral nervous system.
And that would prevent a lot of those side effects that you get from opioids, such as sedation and things like that. Yep.
Absolutely.
So we've got some great questions coming through. I might just bank some of these so we get to them when we do the Q&A session, because I know we've got a lot more content that we just want to share with you all. Janelle, in terms of understanding what's actually going on in the community and improving the quality of outcomes and services for people experiencing pain, chronic pain, can you just talk us through a little bit about what ePPOC is doing to help address that?
Sure, thank you. I'll just put up a little PowerPoint if I may, and I'll share my screen, and hopefully you can now see my presentation. Yes?
Can everyone see that? I think what I can see is a bit different, but hopefully everyone can.
Okay,
yes, perfect. Thank you.
I'll just start. Lovely. So ePPOC, the Electronic Persistent Pain Outcomes Collaboration, we started in 2012 with it was a joint initiative from the Faculty of Pain Medicine and the New South Wales Agency for Clinical Innovation. A group of experts got together and thought, you can't fix what you don't know. So one of the things we wanted to do was be able to see what was going on in the pain sector for people living with chronic pain every day. So ePPOC works with pain services throughout Australia and New Zealand who want to be involved in continuous quality improvement. So what we've done is embedded standardized and validated clinical assessment tools into the routine care of people with chronic pain. We then feed back the results. We identify with the services opportunities for quality improvement. We also facilitate collaboration and research amongst the wider pain sector, and we conduct research ourselves. But one of the main things we've done is establish 9 Australasian benchmarks for the quality care of people with persistent pain. So these 9 benchmarks are ones related to the experience of pain for the person, related to mood, including depression, anxiety, and stress, and relating to cognition, or the way you think about pain. And so you can see the benchmarks there on the side, and the percentages are the threshold of expected improvement, clinically significant improvement of people. And the really amazing news about our benchmarks, since we started them not 5 years ago, is that the services are already pushing up the thresholds. For example, for pain interference, which is a measure that asks people, how much does pain interfere in your life, in day-to-day activities, in sleep, in mood, in relationships, etc. And that we started with a benchmark of 50% of your patients should have clinically significant improvement. That benchmark has now been risen by the services, if you like, pushing it up through continuous quality improvement to 70%. And so that's a really good news story about how benchmarks work, because you can't fix what you don't know. And if you know how you're performing compared to other services, you can work on areas to improve. So we help out the services help out patients. So through our software, when the patients complete the questionnaires, an individual report is automatically generated so that clinicians and patients can use it for shared care goals and to guide care. And it's a 14-page long report that gives you progress throughout. The other way we help the actual pain service is twice a year we provide them with a really detailed report, it's about 60 pages long, of their performance throughout that time, and they can then work together as a team to look at ways to quality improve. We also provide benchmarking workshops so the pain clinicians and all the pain teams can get together once a year. Well, it's changed a bit lately, of course, but we still get together online, but we get together once a year so that they can share and they can see the results of how the other services are doing, and if they want to share where their position is on the results, and they can do a bit of learning from each other and networking. So that's really important. The other thing we do at ePPOC is a lot of research based on the de-identified data we receive from services. And in fact, a recent paper we just published was about where we looked at people who ceased opioids as part of their care. And actually they had better outcomes than those who weren't able to cease their opioids. So that's an interesting paper. You can see that on our website. Just a little snapshot of, so one of the things we ask patients overall is like, how do you feel overall at the end of your care? And so because we ask them questions at the start of care, at the end of care, and then 3 to 6 months after care is finished. But you can see here that overall, almost 3/4 they felt better overall after receiving care from one of the specialist pain services in Australia and New Zealand. And almost 3/4 had a positive change in their physical function as well. Another one of our benchmarks is around opioid use, and because it is a goal, only because of the negative side effects of all pain services, to try and reduce the negative aspects of use of opioids. And one of our benchmarks is related to the opioids, and you can see how well the pain services, so the red line is the benchmark, the blue part of the graph shows the results of all of our services grouped together. And in a services report, this is an example report, a pretend pain service, it would show their result where they sit. And our reports also showed trends, and you can see, and represented here by the light blue line is all services. So that is actual true data, and it's showing that all services are really improving and meeting that benchmark. I'll stop sharing now. So that's what sort of ePPOC does and how we work to improve the quality of care and services with chronic pain, for people with chronic pain. And we work, I want to take this opportunity to thank the amazing pain services we work with, because they're the ones at the ground doing the hard work. They then send us their de-identified data, and we work with them in those ways to help improve from a distance. But I really want to acknowledge some of the hard work they do when they're doing that sort of thing.
Thanks, Janelle. Thanks so much for sharing that with us. I know we've got lots more questions coming through, but before we get to that, I just want to jump to you, David, just to talk around the alternatives to medication. So we've talked about the complications with using opioids and what the alternatives could be. Is there anything else that people can do to help manage the pain that they're experiencing?
As I said, there are a number of small molecules that have been developed over the years for treatment of pain. Gabapentin, pregabalin are widely used. Again, they're not ideal to use for long term. They are much stronger than, say, the Nurofen, the non-steroidal anti-inflammatory type drugs. But really, for chronic pain, you want to the peptides that we've been developing actually target those receptor ion channels that are found predominantly in those sensory nerves. So, and quite often in chronic pain, you can get up expression or upregulation of those ion channels or membrane receptors. So these are proteins that are found in the nerves, along the nerve fiber or at the nerve terminal, or in the cell body, the dorsal root ganglion. So that's what the peptides are targeting. And fortunately, they're not targeting, receptors in the heart.
And there's been a few questions and comments coming through asking whether the peptides that you're talking about, is a medication, a peptide-based medication, already available for GPs to prescribe as an alternative to opioids, or is it are they still in development, not yet out on the market?
Well, certainly Gynecological or Prealt, as it's called, which was approved by the FDA back in 2005, is used, and it is predominantly to, as I said, to people that can't tolerate opioids. But there's a real need for new analgesics on the market. And, I think particularly with what has happened over the past 5 years with increasing number of opioid deaths, and it's largely because of addiction, people develop tolerance to the opioid where it loses its effect. That's why we really need a new drug or a new analgesic.
One other medication is also a tricyclic antidepressant called amitriptyline. Some of you may be familiar with. So that's and in lower doses than you might have for depression, although we do know that depression and mood disorder go hand in hand often with chronic pain. So people are often on antidepressants as well. And that's part of the medication-related management of chronic pain. Of course, there's a lot of other types of evidence-based care for chronic pain, which I'll chat when Kate gives me the go-ahead.
Go for it, Janelle.
Okay, so I think it's important to know that there are some true evidence-based care for chronic pain. There's two in particular. One is use, and I've already talked to you about how complex chronic pain can be because it does make changes in our brain. And so that only lends itself to the care for chronic pain being more complex. So before we dive in, maybe it's time for the poll about what are the evidence-based methods for treating chronic pain? Can you see that question?
Yeah, hopefully everyone can see that now.
So the most evidence-based methods for treating chronic pain include a combination of A, education and strategies to enhance activity, psychological health and self-management, or B, opioid medications, rest and stress management, C, medical care, medication and meditation, or D, Tai Chi, yoga and pacing.
I'll give you a few seconds to tick the answer that you think is correct. Not many people are thinking Tai Chi, yoga and pacing is the answer. All right, I'll end that poll now and share those results with you.
Yeah, oh, that's awesome. Thanks for that. In fact, Tai Chi and yoga and pacing are things that are used, but the most evidence-based management of chronic pain is using a multidisciplinary team. So that's because we talked about pain, chronic pain having a biological, psychological and social aspect. Ideally, the minimum would be some medical support, some psychological support, and also some physiotherapy. That's the very minimum. Of course, a multidisciplinary team clinician could be many things, from a nurse to a social worker to an occupational therapist but at the very minimum, you need to have a multidisciplinary team looking after your care. And one of the other most evidence-based therapies is cognitive behavioral therapy, because if the brain has changed itself to the negative, cognitive behavioral therapy works to change the brain back to the positive. That's putting it kind of simply, but that's the best way to describe it. And so at a pain service, you're probably wondering, what happens at a pain service? So at a pain service, the things that they will really focus on is, one, education. Education is empowering for people to learn about the actual physiology of chronic pain and what it does to your body. It helps validate your pain, that your pain is real and it's actually making changes in your body. And it also signifies that you're going to have some work to do. And just if you were going into battle, you wouldn't take one weapon. You're better off having lots of different weapons to target this. So the other thing is graduated physical activity. So that's where the physiotherapist comes in, and they work with people to look at pacing and to do different types of safe movement and to get people moving, because we know that keeping people moving is really important in chronic pain. And then the other one is psychology. And that, of course, as I mentioned, involves cognitive behavioral therapy, but mindfulness is really important. And also being able to manage, upskilling us, if you like, to deal with stress and anxiety and negative emotional thoughts. And the last one that services focus on as well is self-managing. So basically, they're upskilling people with chronic pain to be able to build into their life, coping skills, moving skills, and the ability to deal with flare-ups as they arrive, because they inevitably do. And so rather than them wiping you flat when you have a flare-up of your pain, you have the built-in skills to start dealing with it, and the support you need from the team at the pain service. So they're some of the things that are really important when it comes to dealing with your chronic pain.
Thanks for talking us through those. I imagine that can be a whole session on it by itself, couldn't it? So Catherine, hopefully that's answered or gone some way to explaining your comment around medication not being the only answer. But somebody else has asked, how can people access these centres for pain?
Okay, so that was going to be part of my...
I think I'm jumping ahead, aren't I?
It's absolutely fine. Now is a good time. So I guess, look, I'm going to be honest, there is quite a wait time to get into a chronic pain service. So I'm just going to say it right out there. So the best place for people to start is with their GP. And when it comes to chronic pain, you've got to be your own personal advocate. You've got to go in there and fight for yourself. So you start with your GP and ask for a referral to a pain clinic for multidisciplinary care. That's important. And that's what every pain clinic will provide. But in the meantime, whilst there may be a wait. So don't let that deflate your need to fight for yourself. In the meantime, you can educate yourself about chronic pain. And I believe Kate's going to put up a bunch of links for you to all go to, and you can learn much more about chronic pain. Secondly, you can ask your GP for a chronic disease management plan, and that can include sort of partially funded visits for physiotherapy and for psychology if you need it. So those are important sort of backup things that you can do in the meantime while you're waiting to get into a pain clinic. But it's important that you start this process yourself because sometimes the wait it's unbearable for some people. And if you can get the support starting early with your GP, some psychological help and some help with a physiotherapist to get you moving, you'll be much more, and education, of course, through the links, you'll be much more prepared when it's time to, when you finally do get your referral to the pain service.
Great, thanks, Janelle. So I think I might just jump to some of our questions now. So thank you so much, by the way, everybody, for sending through your questions and being so active in the chat function. It's really great to hear from you all. The very first one from Terry. Terry wants to know whether it's possible to get the reference for the paper that shows the possible increase in pain with the use of opioids that you mentioned earlier, Janelle.
Not right now, but yes, I can
we'll
get
be able
that
to
to
send
you.
that through.
Yes, we will.
So I'll send a follow-up email to everybody with this additional information that we have. Milana, sorry if I pronounced that wrong, asks, is there a role for peptides to address gynecological pain?
So there are a number of peptides. So peptides don't just come from the venom of cone snails. Peptides are found in snake venom, they're found in spider venom. In actual fact, currently there's a development going on between researchers at the University of Queensland, the Victor Chang Cardiac Research Institute, and Monash University in development of a peptide that comes from the spider venom for treatment of stroke. And it's been on the news recently, but that's certainly in development at the moment. As I said, I think the use of peptides, the real advantage of peptides that nature makes is that they tend to be very selective for their target, unlike small molecules. And that's been the problem with a lot of small molecule drugs, is they're off target or side effects. I think nature's made these peptides that are very selective for their targets, and in so doing, minimize the side effects. So there is a lot of work going on at the moment with the discovery of new peptides and the potential use as therapeutics.
Thanks, David, and thanks for the question, Milana. Catherine was mentioning around, where are we?
I can see one. I can see one that says, "Do you need a referral to access a pain clinic?" It is better to get a referral to a pain clinic because it's more informed by, for example, you know how I said pain has a biological, psychological, and social aspect. So the GP will want to rule out any biological causes of pain that can be possibly dealt with through some form of treatment. I mean, if you've got knee pain and you need a knee replacement, then you need a knee replacement. No form of chronic pain management is going to cure a broken knee. So it's always better to start with your GP to get a referral to a pain clinic, because it's a more informed referral.
And there are some comments here, Janelle, around unfortunately people going to their GPs and not feeling like they're not getting the support that they need. I know I'm going to send around some links for people in the follow-up email. Where should people go if they don't feel like they're getting the right support from their GP?
Look, I mean, my daughter, one of the reasons I'm involved in chronic pain research is because my daughter she's in her 30s. She has chronic pain after pregnancy and been living with it for 6 years now. And she would say she has had to keep, that's why I brought in the concept of fighting for yourself. So you have to keep going until you get a GP that will listen to you. And part of that is speaking the language they speak. And so therefore, that's where the education, so educate yourself about chronic pain. What is it? What you're experiencing, so that you can better speak to your GP and talk to them about what you're experiencing and when you ask for a referral to a pain clinic.
Thanks, Janelle. There's a question here from Nikki who wants to know, would peptides be okay to use in the case of autoimmune diseases such as rheumatoid arthritis? David, is that something you might be able to answer, or?
Can you say that again?
Yeah, Nikki would like to know whether peptides, would be okay to use in the case of an autoimmune disease such as rheumatoid arthritis.
Yes, look, peptides are being developed for many diseases. There's actually peptide-based cancer vaccines now. Peptides are being used for tumor detection, for targeted radiotherapy, because you can put tags onto these peptides. So, you know, people are becoming aware that peptides can be used for many different things. Most of these peptides, I should say, are fairly small. They're from 10 to 40 amino acids. So they're relatively small compounds, but you can attach and modify them quite easily. Most peptides are found in the venom of, say, cone snails or spiders. Then they're folded. So they're folded in a way that they present themselves to their target. So nature's done a lot of the work. So in terms of different types of conditions or diseases, there's a lot of development going on at the moment. And as I said, one of the current ones going on is peptide-based cancer therapies.
Thanks, David. Sorry, over to you, Janelle.
I was just going to say as well, I saw a couple there about, so in the links that I've sent Kate as well, they're both Pain Australia and the ACI and Chronic Pain Australia have developed a list of recognised pain services. So if you're having no luck with your GP, by all means, go to those sites, look up the list of the pain services, find one in your area and give them a call and have a chat to them about what you should do next. And that's part of going into battle for yourself. And I see one about, is a pain clinic different to a rehab unit? Yes, they are different, although they will have, you know, graduated getting you moving again and dealing with your pain. And there's not usually the psychological element, although again, rehabilitation is a very broad area as well. And there's many types of rehabilitation. So, but they are essentially different.
Thank you. Gabriella wanted to know, David, I wonder whether you might be able to type in the chat the name of the peptide medication that is, or the medications that are currently being used, or perhaps share them with me and I'll share them with everybody on the follow-up email.
I wrote a review earlier this year, which is all the peptides that have been used drug development, and it'll give you a pretty comprehensive overview of which peptides are currently being used, and and what treatments. So diabetes is a fairly big one at the moment. Peptides being used for treatment of type 2 diabetes, but certainly in terms of arthritis, in terms of other conditions, not that are not just pain.
Thanks, David. I've just added in the chat there the links that Janelle has been referring to, but I will, as I said, put those in a follow-up email to everybody as well.
I also provided the link to the paper that one of the people asked in the question. In the answer, I published an answer with a link to the paper regarding opioid hyperalgesia, but I'll also give it to you, Kate, to send through.
Yes, please, that would be great. Thanks,
No
Janelle.
worries.
We did have a couple of questions from earlier from Gabby. She wanted to know why do you think opioid prescriptions are on the rise? Do we have an increasing problem of chronic pain?
I think with anything, as we become more aware of what chronic pain is and that we need help for it, more and more people are coming forward to advocate for themselves as far as pain goes. And often because people need to learn about what's going on in the background of chronic pain. And we're also taught from a very early age that, you've got pain, have a Panadol, like have some sort of, it's about taking a pill and look, we're in a society that likes a quick fix, and an opioid might seem like a quick fix at the start, but it's not the long-term fix. And so I think it's just about people are becoming increasingly aware. But certainly we do know that 20% of people live with chronic pain even now as we're speaking. We are living longer as well, so.
Now I know, so we're coming up to the end of the webinar. Janelle, David, could you just offer perhaps a takeaway for our audience, or perhaps some good news for them to take away with them following the webinar? Perhaps to you first, Janelle.
Okay, so as I said, yes, chronic pain is complex, but there is a light at the end of the tunnel, because we do have evidence-based care for chronic pain through the many pain services in Australia. So my takeaway, if you have had pain that's lasted greater than 3 to 6 months and you're not getting anywhere and it doesn't seem to be improving, start with your GP or look up those pain clinics on the links that I've sent, because we know the evidence suggests that you need multidisciplinary care. So you need medical, psychological, and physiotherapy at the very least. And then we also know that will involve cognitive behavioral therapy. So it's complex, but it's fixable. But you need to be the one who will fight for yourself. So start that journey today.
Thanks, Janelle. Any takeaways, David? Any last message?
Well, there's certainly a lot of active research going on in terms of development of new therapeutics. And, I think the one thing we didn't mention is really the total cost of chronic pain, the effect on the economy. In 2018, when Deloitte Economics did a review, it was estimated to be close to $140 billion. And this is associated with health system costs, productivity costs, due to absenteeism, reduced employment, and other costs and loss of well-being. So it has a huge impact on society, and I think we've got to do better than opioids. And I'm optimistic that these new peptides will make a difference once they get it out into the population.
It sounds like it's all going in the right direction, David, and thank you for all your work researching these alternatives, and hopefully we'll see them available to us. We know research takes an incredibly long time, but hopefully in the not too distant future, there'll be alternatives for people to use, readily available for people to use. So look, we've just, actually we're a bit late, we've ticked over 1:30, so I think we'll leave the webinar there. Thank you so much firstly to our panelists, to Janelle and to David, but also a big thank you to everyone who's taken the time to dial in today and shared experiences and asked those questions that's got us all thinking, I imagine. Just really appreciate everybody's time. We do have another webinar tomorrow if you're available, raising awareness around Huntington's disease. It is a rare disease, but there's some fantastic work happening at IHMRI. So if you haven't already, go to the Eventbrite page. I'll send that along with the follow-up email. And register for that. We've got Gabby Phillips, who's just doing some incredible work into Huntington's disease, and also Robin Russell from Huntington's New South Wales ACT will be joining us to share what practical services and help there is out there for those people living with Huntington's and those caring for people. If you haven't already, I encourage you to check out our website, ihmri.org.au, and there's lots of valuable information there about the type of research that's happening right here on our doorstep. We're just based on the university campus. It's an incredible facility, and the research that's going on is world class. So take a look at that. We also are doing clinical trials. Even during COVID, we are able to continue some clinical trials. And when things get back to normal, we're always looking for people who might be able to participate in those. And we also have a newsletter that comes out every other month, just letting people know about the type of research that's happening and any events that we've got coming up. We're hoping to have an open day. We're just too late with the COVID restrictions coming into effect. I think on the 28th of June, we had an open day all planned and scheduled and organised for the 30th of June. So of course that didn't happen, but it was just a postponement to next year, to when things do open up. So we would love to see many of you there to take a look around the facilities and meet the researchers and find out firsthand what's going on. Apart from that, I think that's it for today. So again, huge thank you to everyone. Really appreciate you coming today, and we'll see you at the next webinar. Thanks everybody.
For having me.
You're so welcome. Thanks, David.
Bye.
Thanks, Janelle.
Bye.
Bye.